Hello, everyone, and welcome back. My name is John. I'm one of the final year critical care fellows at Dalhousie University. Thank you so much for tuning in today for part 2 of my 7-part learning module on oxygen delivery and oxygen consumption for the evaluation of oxygen balance in hypoxemic respiratory failure requiring VV ECMO. Previously, we reviewed general lung function, the basics of oxygen delivery, and briefly reviewed metabolism. Today, we'll be talking about hypoxemia. Our objectives today will be to discuss hypoxemia as it relates to ICU admissions, introduce the concept of the AA gradient, and discuss how we can use it to narrow our differential diagnosis for the cause of hypoxemia and hypoxemic patients, as well as review the broad categories of hypoxemia. To start, hypoxemia is a state of abnormally low levels of oxygen in the blood. It is a life-threatening state common to critically ill patients. Large cross-sectional studies across multiple ICUs have estimated that approximately 50% of all patients admitted to the ICU are hypoxemic at any given time. Although hypoxemia has several definitions, a common definition, and the one we'll use for this learning module, defines hypoxemia as a PaO2 of under 80 millimeters of mercury on an arterial blood gas sample. Of note, other definitions define hypoxemia below 60 millimeters of mercury on a blood gas as well. Hypoxemia is particularly relevant because if left uncorrected, hypoxemia can progress to tissue hypoxia, that is insufficient oxygen at the cellular level, resulting in the cessation of aerobic metabolism and necessary conversion to anaerobic metabolism to sustain life. Of course, this is not without its complications, as mentioned in the previous section. There are many causes of hypoxemia, which are generally divided into 5 broad categories as shown here. Running through these quickly, hypoventilation refers to a patient not breathing enough to meet metabolic demands. An example of this would be a low respiratory rate in the setting of an opiate overdose. The second cause of hypoxemia on this list is low inspired O2 tension or low PiO2. This occurs when atmospheric conditions result in insufficient oxygen delivery to patients. An example of this would be breathing at the summit of Mount Everest, where the atmospheric pressure is generally reduced, reducing the overall delivery of oxygen to the alveoli within the lungs where gas exchange occurs. The third cause of hypoxemia on this list is diffusion impairment, which results in hypoxemia due to pathologic changes at the alveolar capillary membrane, impeding oxygen diffusion into the blood. An example of this would be interstitial lung disease or pulmonary fibrosis. The fourth cause we'll discuss is a right to left shunt, which is a situation that occurs when blood is able to pass either through the lungs without being oxygenated by the lungs or around the lungs altogether, thus contributing deoxygenated blood directly into the systemic circulation. An example of this would be a ventricular septal defect or a VSD with a high right-sided pressure shunting blood from the right heart to the left heart. And finally, rounding out this list is VQ mismatch. VQ mismatch is a situation that occurs anytime there's normal or near normal perfusion to a part of the lung that is receiving inadequate ventilation, or vice versa. I find this image to be the most helpful in understanding VQ mismatch. The left side of the image illustrates normal physiology where all of the deoxygenated blood entering the pulmonary circulation has time to be oxygenated before it leaves the lungs and returns to the left heart. On the right side of the image, however, half of the blood proceeds through the lungs as normal and thus exits fully oxygenated as seen here. The problem results from the second portion of blood flow over here that is perfusing an alveolar unit that is not receiving ventilation, and therefore the blood leaving this portion of the lung does not receive any oxygen. This deoxygenated blood then mixes with the normal oxygenated blood draining from the normal portions of the lung. This is problematic because the resulting mixture of blood is not fully oxygenated and can even be hypoxemic depending on the proportions of blood being contributed from the normal and abnormal parts of the lung. When we see a hypoxemic patient in consult for the ICU or in the ICU, it may not be immediately apparent what the cause of their hypoxemia is. To help us narrow our differential diagnosis, we can look to helpful equations like the alveolar arterial gradient, or the AA gradient for short, which is represented in the formula you see here, to help us narrow our differential diagnosis. In this formula, the P capital AO2 is the oxygen concentration in the alveoli, and the P little AO2 is the concentration of dissolved oxygen within the blood. Simply put, the AA gradient serves to compare the amount of oxygen in the alveoli, the P capital AO2, to the amount of oxygen dissolved in the blood, the P little AO2. Here's a visual representation of what these values mean. We can calculate the P capital AO2 with a formula, and we can measure the P little AO2 from our arterial blood gas. The equation for estimating P capital AO2 is seen here. This has just been included for reference or interest only. It's not overly important to the objectives of this learning module. If needed later, the attached spreadsheet, which we'll talk about, will calculate this value for you automatically. Once we calculate the AA gradient, we compare it to a normal AA gradient to see if it's normal or if it's elevated. A normal AA gradient is generally considered to be between 5 and 25 millimeters of mercury for young adult patients who are non-smokers and breathing room air, but increases with age according to the formula seen here, as well as by an additional 5 to 7 points for every 10% increase in FiO2 above 21% being delivered to the patient. As mentioned, by assessing whether the AA gradient is normal or elevated for a patient with hypoxemia, we're able to narrow our differential diagnosis somewhat. The general breakdown of this is represented in the table. So with that, let's briefly run through two case examples. For this case, and the other cases that come up in this learning module, you can follow along with the attached spreadsheet to complete the calculations for you. For the next two cases, we'll use the workbook called AA gradient. And to perform the calculations, simply input the values into the yellow cells. Of note, all the values that are required for the calculations are going to be highlighted in yellow. The AA gradient will be computed in the light blue cell, as seen here on the bottom. And below that value, in the box called AA gradient interpretation, you'll also be able to see an automatic interpretation of these results being reported as either normal or elevated. So looking at case 1, we've got a 40-year-old male who's brought to the emergency department at the Halifax Infirmary via EHS with a suspected opiate overdose. His respiratory rate is 8. An arterial blood gas sample with the patient breathing room air is drawn by the respiratory therapist and reveals hypoxemia and acidosis. The SpO2 on the cardiac monitor is 88%, and you see the corresponding ABG here in front of you. By entering the values of PCO2 in purple here, as well as the PaO2 in green, the FiO2 in red, and age in orange from the ABG in question, we can calculate the AA gradient, which comes out to 9. From the formula for expected AA gradient, we also see that this computes to 12.5. As our derived value of 9 for the AA gradient is less than the expected value, and certainly less than the generally accepted range maximum of 25, we can conclude that the AA gradient for this patient is not elevated or is normal. According to the classification of hypoxemia found in the table here, we can narrow the etiology of the patient's hypoxemia to alveolar hypoventilation or low PiO2. As Halifax is approximately at sea level and the patient was breathing room air at the time of the ABG, we can conclude that the cause for the patient's hypoxemia is likely hypoventilation. If the patient were able to breathe a normal amount, he would easily be able to replenish the fresh air in his lungs, increasing the amount of oxygen available for diffusion, fixing his hypoxemia, and expelling the excess CO2, fixing his hypercapnia and acidosis. A normal AA gradient essentially indicates that the amount or partial of oxygen in the lungs at the level of the alveoli and the amount or partial pressure of oxygen in the blood are similar, or at least represent what would be expected under normal conditions. Because the values are similar, their difference is small, highlighting normal oxygen diffusion across the alveolar capillary membrane. This is a visual representation of what this kind of looks like and shows oxygen in both compartments are similar. And from this, we can conclude that there's no substantial issue with diffusion of oxygen. Now let's look at a completely different situation illustrated through another case. Again, you can use the attached Excel spreadsheet in the workbook called AA gradient, along with the values highlighted in yellow from the ABG on the next slide to calculate the AA gradient in order to narrow the differential diagnosis for the cause of hypoxemia in the case. So for example, case number 2, we've got a 55-year-old female who's been admitted to the ICU with a diagnosis of hypoxemic respiratory failure secondary to community-acquired pneumonia. She's been intubated and is mechanically ventilated for her hypoxemia. At present, the FiO2 on the ventilator is set at 80%. An ABG is performed, revealing a respiratory acidosis and hypoxemia. By entering the values of PCO2 in purple, PaO2 in green, FiO2 in red, and age in orange from the ABG in question, we can calculate out the AA gradient, which comes out to 430. This, of course, is much greater than the calculated or expected AA gradient of 12.5, and as such, we can say that the AA gradient is up. This essentially means that there's a much higher concentration of oxygen required at the level of the patient's alveoli to attain the same PaO2 as in case number 1. This suggests that there's a problem with either diffusion, shunting, or VQ mismatch based on our table of causes of hypoxemia seen here, as the partial pressure of oxygen in the blood remains low despite the increased amount of oxygen being supplied to the alveoli. A simplified illustration of the conditions of an elevated AA gradient is shown here on the left side of the slide. As mentioned previously, an important cause of hypoxemia, which is very relevant for this learning module, is that of VQ mismatch. One proposed mechanism of hypoxemia occurring in ARDS is inflammatory damage to the very important alveolar capillary membrane responsible for gas exchange within the lungs. To understand how inflammation or even fluid in this area can impact oxygen diffusion, we can briefly look at Fick's law that describes diffusion. As we have discussed previously, diffusion of oxygen is dependent on the concentration gradient of oxygen across the alveolar capillary membrane. That is the partial pressure of oxygen in the alveoli, which is the variable P1 here, versus the partial pressure of oxygen on the other side of the membrane in the blood, represented with the variable P2. Manipulation of these partial pressures will be discussed shortly. In addition, the diffusion of oxygen across the alveolar capillary membrane is also dependent on the thickness of the membrane, represented with the variable T, the surface area available for diffusion, represented by the variable A, and the diffusion constant of the substance diffusing across the tissue, which is the variable D here. The diffusion constant is a physical constant dependent on the molecular size and other properties of the diffusing substance. Of course, in this case, we're talking about oxygen. You can imagine that during a process such as ARDS, as seen on the right, compared to a normal chest x-ray on the left, where there's inflammation causing damage to the lung parenchyma, that this could include damage directly to the alveolar capillary membrane or result in the production of fluid within the alveoli. This inflammatory damage occurring in ARDS, at least in part, impacts the alveolar capillary membrane as depicted here. This damage causes increased thickness of the alveolar capillary membrane, which we know from Fick's law is inversely proportional to diffusion, and as such, overall diffusion is reduced. In addition, some alveoli are so severely damaged that they can no longer participate in gas exchange. The overall area, A, of the lung available for gas exchange also decreases, which results in further proportional decrease in oxygen diffusion. If oxygen diffusion is reduced to a significant degree, clinical hypoxemia can result. If an inflammatory process affects only a small portion of the lungs, it's possible that the remainder of the unaffected lung would have enough reserve to sufficiently compensate to sustain adequate diffusion and thus oxygenation. But if too much of the lung is affected by a pathologic process, this could result in hypoxemia and ultimately hypoxia at the tissue level if not addressed. From this, we can appreciate that VQ mismatch is a problem contributing to hypoxemia. And to make matters worse, because many of the alveolar units are unable to contribute to gas exchange at all, which is the main problem, management of hypoxia from VQ mismatch can be challenging, as increasing this supply to VO2 may result in minimal improvements. And that brings us to the end of part 2 of this learning module. We defined hypoxemia as having a PaO2 of less than 80 millimeters of mercury on an arterial blood gas sample, and discussed the burden of hypoxemia and common etiologies for hypoxemia in the ICU. We also introduced the concept of the AA gradient and reviewed how to calculate it and use it to narrow our differential of hypoxemia. Thank you so much for your attention today. I hope you can join me for part 3 next, where we will discuss the management of hypoxemia.